So good evening, everyone. My name is Bernabe and I'm very pleased to welcome all of you on behalf of the University of the Philippines Alumni Association of Washington, D.C., Maryland, and Virginia to the second installment of our three-part COVID-19 webinar series. Today's session will be recorded, so please keep your microphones muted to ensure the quality of the recording. Copies of this presentation will be provided to today's registered participants. Just to give you a recap, last week we heard from Mr. Ted Tesoro, a survivor of COVID-19. During his talk, he shared about his experience living through a severe case of the disease. Today, we will hear from a medical expert, Dr. Nathalie Quion, about the latest updates on COVID-19. She will also provide some practical advice on recognizing its common symptoms, as well as the latest information on testing and treatment. Our speaker has prepared a rather extensive presentation for all of us, which would take around 15 minutes, after which we will open the floor for some questions from our audience. Hopefully, we will be able to complete this episode within the 30 minutes we have allotted. So we are very fortunate to have this opportunity to hear from our guest speaker and leverage her knowledge, training, and experience in understanding this rather scary disease caused by the SARS-CoV-2 virus. Dr. Nathalie Quion, or Nanette as she is fondly called by her friends, has a very impressive resume. Her CV, I will only give a very brief highlight during this introduction, so we will have more time learning and hearing from her. She is a clinician, medical administrator, and educator. The main focus of her work is in medically underserved and immigrant communities of Springfield, Massachusetts, Arlington, Virginia, and Washington, D.C. Currently, she is the medical director of Children's National at Columbia Heights. She has a BS in zoology from the University of the Philippines, received her MD from the University of the East. She has a master's in public health and epidemiology, I hope I said that right, from the University of Massachusetts Amherst. She also completed the master teacher program for medical educators from the George Washington University. Her medical training includes a general internship at the University of the Philippines Philippine General Hospital, or UPPGH, in Manila, a pediatrics internship at the University of Texas Health Science Center in Houston, and a pediatrics fellowship at the University of Massachusetts Memorial Medical Center in Worcester, Massachusetts. She is part of the American Academy of Pediatrics. She has, in fact, was a recipient of a Special Achievement Award in 2016 from its DC chapter. Dr. Nanette was also a clinical associate professor at the Georgetown University School of Medicine, Department of Pediatrics, and assistant professor at the George Washington University School of Medicine. Aside from teaching, she has also published medical studies and reports, most recent of which was a paper from spring 2020 for the section for Global Health newsletter of the American Academy of Pediatrics called The Polio and Measles Outbreak in the Philippines, a case for an independent national advisory committee. I could really keep going on and talking about our speaker's accomplishments, but I will stop now or we will run out of time. Before I turn it over to our speaker, I'd like to remind everyone to keep their microphones muted during the presentation. Please use the chat box for any comments or questions, which we will refer to during the Q&A portion after Dr. Nanette's presentation. So Dr. Nanette, I will mute myself now and hand the floor over to you.
Thank you very much for inviting me to talk. Or have this discussion. I would like to start off that this should be an informal discussion. I don't want to be the only one talking. This is just hopefully a means for us to raise points and also talk about the different things about COVID-19. So I have no conflict of interest. I will discuss a couple of medications and vaccines and stuff like that, but I don't get any anything in return for that. And then hopefully within the next 30 minutes, we will learn a little bit more about the clinical presentations of COVID, and we'll discuss the updates on testing and treatment, which I think is the most important thing that has been coming up ever since we've had this pandemic going on. And also understand some of the public health approach to controlling COVID or this pandemic. My other disclosure is that I am, as was mentioned, I am a clinician and in general pediatrics. I am not a virologist, I'm not a bacteriologist, I'm not a specialist in infectious disease, I'm not a critical care doctor or a pulmonologist. My approach to this is mainly from my experience as a clinician and in the community, and also as a public health person. Since I work mostly in as administrator and doing a lot of population health, and also because I teach also public health in the medical school at GW. So we'll start with a case, and hopefully this will start us at least thinking about COVID. I started a case with Michaela, who's a 58-year-old who works in the bank and presented with the 4-day history of fever, cough, and colds, and started complaining also of muscle aches and weakness, and eventually had difficulty of breathing. She had no history of travel to China, Korea, Italy, and Spain. And believe me, in March, when this all started, at least gaining attention in the United States, part of our algorithm in terms of approaching patients was still talking about travel history. And when the community, when it was determined that most of the cases now were spread by in the community, this travel history became unimportant. So what are the usual symptoms that most people with COVID have? And this is probably some of the symptoms that Ted had before, which he probably talked about last week. So and I think the most important thing about this slide is that most patients will only have this, and it's only a smaller proportion of patients, however, that will have the worst symptoms, and that include and these are the symptoms that basically would trigger you to seek urgent care or emergency help. Definitely trouble breathing, persistent pain or pressure in the chest, and definitely confusion. And the confusion and the trouble breathing, inability to wake or stay awake, or even the bluish lips really goes to the fact that, that the COVID pneumonia does cause a significant hypoxia or decrease in oxygen. So it's very, very important that once you start having these symptoms that you should be going to the emergency room or calling your medical provider. So, and what we're learning now, I mean, it's been since December when the pandemic or the outbreak started in China, that there are certain groups of groups that are just more, that tend to have a lot more, who become a lot more sick or are just become moderately or severely sick with COVID. And these are older people, greater than 65 years old. And it's very unfortunate that most of the outbreaks that are happening here now in the United States are in nursing homes and long-term facilities. And those with underlying medical conditions. And those underlying medical conditions could be chronic lung disease, heart conditions, definitely anyone who is immunocompromised. That means basically anyone who has an immune system that is compromised. And that could be people who had prolonged intake of corticosteroids for one reason or another, or who had also received chemotherapy, or have bone marrow and organ transplantation. These are definitely high-risk people and should really be isolated from the virus. Unfortunately, it tends also to affect people who had severe obesity, diabetes, kidney disease, and liver disease. One of the things that that really makes this very dangerous is that and what has caused a lot of the mortality in COVID is what is called the cytokine storm, which is when there's high levels in the immune system of this particular protein. But it's seen in other diseases as well. But the most important thing that happens with this is that basically your body start attacking yourself. And this is where the really bad reactions happen. And unfortunately, the mortality really becomes high. I just want to mention this. This is one particular syndrome that we are discovering here in children. And it's very rare, but it can happen. It's mostly, it was not seen in Asia. It wasn't seen in Korea, China, and Japan, but it was noted in Italy and UK, and also reported a few cases also in New York. And probably the reason is the strain, the COVID strain that affected New York was actually the strain that came from Italy. So just be aware that those are the symptoms of what we call the MIS-C, which is COVID basically, but it's like Kawasaki's for the medical professionals who are in this group, but it's very particular for a particular presentation of COVID in children. So let's just go quickly to testing. I think that's the most important thing that that's in everybody's mind. Do I need to get tested? So this is a really nice slide that I want you to be able to look at when you get to the slides, because this really determines why that the testing that we are doing now, which is the PCR, sometimes can have high false negative results, because it really depends on what time in this natural course of the disease are you getting tested. It also talks about, so the PCR also, and again, the second kind of test that we are also going to be talking about a little bit is the antibody detection. So those are the two kinds of tests that are currently that is currently available. So there are a couple of tests that are now available that are PCR based. One is that you've been seeing, the one that was in the picture in the start of the part on testing, and that's basically a swab that's basically placed on in the very back of your nose or your oropharynx. So this is the one that's pretty much been used. And upcoming tests that are coming down the pipe. So the problems with the nasopharyngeal and the oropharyngeal test, it does require somebody else, like a healthcare provider, doing it. It also requires a swab being used. And this is very taxing to the system, because you still have a healthcare providers getting exposed as well while somebody's while the test is being done, as well as the swabs are already getting, we're getting less and less of it, and we don't really have a good supply system for it. So we need to come up with other kinds of tests that doesn't require that. So up in the pipeline actually is a test that's being developed from Rutgers, which really just requires you to spit into a cup and you send it. Another test that's being developed and is coming up the pike is a test that uses only your saliva. You basically, again, it's very much like the spit, but this time you're rubbing something in your mouth. Then there are other tests that are coming up, which is not based on the PCR. And the PCR basically is a piece of the virus that is found inside that would be found in any of the parts of your body that is being tested. So it's not unlike so it's very much like different other tests, but it's basically testing the presence of that, of parts of the virus. So it's just very important to remember that, that there is a significant, even in this reporting, which came out in, that there's a significant amount of false negative. And in this, when they were looking at like Abbott ID now, which I think is the most commonly used, there's at least 15% that is in false negative. So don't be complacent. Even though you're negative, it doesn't, especially if you already have the symptoms and you do have the exposure, that's most likely you might have still COVID. So it's still very important that you quarantine yourself or you wear a mask. So then the other kind of testing that is now coming up and is starting to be available, and there's a couple of commercial brands that are out there. So it's the antibody testing, and the antibody testing is basically looking at antibodies, whether you basically have an immune response to the proteins of the virus. And this is important to in terms of our being able to determine how many people actually have had the virus, because people who are asymptomatic basically can have or negative PCR test people can definitely have a more likely antibody testing that is positive, and this would probably determine for us prevalence of COVID-19 in the community. So please feel free to stop me, because I know I'm throwing a lot of public health words there, but please feel free. So it's very important. So as we go forward, antibody testing will be more predominant in terms of our testing, because definitely this is going to be very helpful in us determining what is the herd immunity in a community. So already, even with LA, when they started doing the antibody testing in LA County, they already found out that there's a lot more people who were actually positive who are positive, or what it means is also have had the disease or the illness or COVID-19, but not necessarily had any symptoms. So this just proves to you that there's a lot of, there's a significant amount of asymptomatic people who have had COVID-19. Again, just a warning with COVID, with antibody testing, again, we don't, even though the sensitivity or the specificity of the test might be high, which is basically the ability of the test to test whether a person has the virus or has the illness, or the ability to make sure that the patient does not have the virus. This is still very much in the very beginning phase. And even though a person might have the antibodies, we are not sure how long that antibody will last in the body to protect that person. And so that's still a big unknown. So even though you might have antibodies to COVID-19, still you can't like put yourself in the middle of a crowd of people with COVID-19 and be confident that you're not going to get the virus again. So so still wear a mask, still be careful, because we still don't know. There are still reports actually in China and Korea that there's some people who have had the disease later on test positive for the PCR again. So, so whether that is clinically significant is still a big unknown. I'm going to quickly jump to treatment. So because I do have a short time, is that this is the most important caveat that I have, is that there are no Food and Drug Administration approved drugs for the treatment of COVID-19. That's the most important thing that I need you to all understand, that we're very much in the beginning of this. There was a lot of talk of hydroxychloroquine and azithromycin as a treatment for COVID-19, especially in the early phases and even in the later phases. Basically, there's been a number of other studies that basically has shown that it has not really panned out, that it's not really helpful. There's been a lot of talk about remdesivir, which is an antiviral. So far right now, it's been able to shorten the amount of time basically that the person is sick with COVID. So there's a 31% faster time to recovery with remdesivir. And the other thing that is you might hear a lot is convalescent plasma. It's basically the plasma of a person who has had the virus and being given to someone who is critically ill with COVID-19. And I think it's not yet, the word is not yet out whether convalescent plasma is still very much in an anecdotal phase in terms of the proof. So, so I'll quickly talk about a little bit about herd immunity, because that's where we really want to go as the population, because this is how we're going to be able to go back to some sort of normalcy. So for just to understand that the herd immunity is a condition in which the population, a certain number or percentage of the population is immune to the infectious disease. And when there is a significant amount of people who are immune to disease, this will also protect the people who are not immune, and that's where we want to go. So this just is a quick slide of just showing you how important herd immunity is. Basically how, when you're surrounded with a lot of people who have had the disease or immune to disease, and you are a person who, for example, cannot get the vaccine, you are protected. We're not there yet. We are very much in the very beginning of this pandemic, but that's where we want to be able to go. And it's depending on the virus, we don't know yet, what is the percentage of population that has to be immune for us to make sure that those who are vulnerable are actually protected. Because most people say that the aim is going to be at least 50% of the population, but we don't know yet whether COVID will actually act like that. Of course, how do we get to herd immunity is through a vaccine. And this is how we've been able to do it for a lot of the other illnesses that we know of, like measles, flu, polio, strep pneumococcus, or Haemophilus influenza B is another one. Varicella, chickenpox definitely is another vaccine. But this shows you, this is a coronavirus vaccine tracker that was published just a couple of days ago from the New York Times. So we're not at all close in terms of being able to have a vaccine that will be available. There's about 125 in the preclinical phase, and preclinical phase is when they're still doing animal testing. Phase 1 is when you're testing whether the vaccine is safe. There's about 8 that's going into phase 2, when you're testing if actually antibodies are being formed. And then in phase 3 is where you do have large scale testing. So there's 2 there, but we don't know yet. The word is not yet out how close we are in terms of the vaccine. They're saying maybe as close as the fall, but we don't know that. There's a lot of phases. There was the speaker yesterday that was saying we don't want to, in the world right now where we are challenged with a lot of anti-vaxxers, and when they did the survey already, there was already 27% that are not going to get even a COVID-19 vaccine, even if it was available. So the vaccine might not be the magic bullet that we're looking for. And in this, even in this multiple phases, and what we're trying to do is speed track a lot of the vaccine development. Of course, when you do that, what suffers the most is safety. And when you're putting safety on one side, any couple of adverse reactions can really just sidetrack any vaccine, even though a vaccine can be very effective. So, and we've seen that a number of times, even with the initial polio vaccine, or we were talking about dengue vaccine in the Philippines, how that created a big anti-vaccine movement. And so we don't want to do that. So we have to be very careful. We can't about the vaccine. So what is our new normal? And this is where probably we can spend a little bit more time. So this is I think that's the That's the going slogan right now. I protect you, you protect me, and this is how we're going to survive this pandemic. Just a quick question. Do you know what scene? I know there's a lot of these Facebook things about identify this scene. I'm wondering if anyone, we can open the mics and see, or a few people who can tell me what scene is this, picture coming from? Any guesses? It is relevant to what we're talking about, I promise. Any guess?
Isn't this from Downton Abbey?
Yes, yeah, exactly. Very good. I thought no one would get this, but very good. I'm a Downton Abbey fan up to season 4 when Matthew Crawley died. After that, I didn't watch it anymore. So that's a scene where Matthew Crawley is actually holding the hand of his fiancée, Lavinia Swires. This is from the the finale of season 2, where she dies. And do you know when it happens? This actually happens on the 3rd wave of the flu pandemic of 1918 to 1919. So it is relevant. Yeah, so I think we can only, how we're approaching this pandemic really relies on us looking at our past and how we've approached pandemics before. So the flu pandemic of 1918 and 1919 is, I think, one of the most dangerous pandemics in recent history. About 50 million people died during this whole time, within the 2 years that the pandemic was occurring. And about 600,000 died here in the United States alone. So just to remind you that actually this is all very familiar. What we're doing now is actually what was being done before in 1918 and 1919. But we are much more ahead because we're learning from them. And second, during this time, they didn't have any antivirals. They didn't also have any antibacterials. And I think what makes this a little bit more dangerous for us, though, is that there was, and why the COVID quickly spread around the world is the availability of light, of being able, people are just more mobile. And that's how most of the spread actually happened to many other countries. So this is just to remind you what happened during the influenza pandemic of 1918. There was a first wave, and there was a second wave and a third wave. This first wave happened around April of 1918. The second wave actually happened during the fall of 1918. And the third wave happened in around April of 1919. So, and this is just to remind you that if we are going to be following the influenza pandemic, which is quite similar in what is happening right now, we are still very much in the first wave. So a very important thing is that we have to really practice social distancing. I'm not going to be able, I don't know whether I'll be able to do this movie, a little short quip, but this is how important, why is it 6 feet? So there's been a lot of studies from, I think this was a 1948 study in the military, where they had a couple of military men who were sick with group A strep, or what caused basically strep throat. And they lined them up, and they put a series of Petri dishes in front of them, and they made them do 3 things. One is just talk, the other one is to cough, the other one was to make a big sneeze. So actually, for most of them, it was actually just like 2 feet to 1 to 2.5. But for the right person in the right time, in the peak of his illness, it can spread as much as 9 feet. So 6 feet is pretty much where we are in terms of recommendation. But again, even though it's 6 feet in terms of recommendation, my thing to everyone, it can actually, the respiratory droplets can go definitely farther than 6 feet. And that's why we also need to wear the masks. And this is just to show you how important social distancing is and how it really, really decreases the infectivity of the virus if we're doing social distancing. This is also to tell you about masks and how important masks are. This is basically, if you're looking at this, this is Hong Kong, where Hong Kong basically has 97, according to the World Health Organization, or this particular study. People wear masks in Hong Kong 97% of the time. And if you look at this, this is from day one, from when the virus started to come out until day 75. And given things being different from in each country, still the one thing that is definitely significant about this is that this is Hong Kong actually in the bottom, and it's Singapore as this other place. So just also in a population, not only in where we know that a mask can, depending on what kind of mask you're using, 95% is really blocked with an N95, 90% with a surgical mask, and a variety of percentages with a surgical mask. So when you definitely with the combination of social distancing and masks, you could see that there's a definite decreasing or flattening of the curve. So, and this also just says the same thing in the population health level. So why do we wear a mask? You have to basically act as if you're infected and not as if you're just not trying to be infected. And these are the different sources that I have here that you can go to. I'm involved in this. What we do is every week we try to put together the most recent studies in regarding COVID from any specialty, from even sociology and even from education. And we put it together working with librarians in our medical library. And we publish this every week. So it's well curated. This is a really good graph where you can really, it's in real time, and you can really look at a lot of countries in terms of how COVID is in terms of its status in different countries. And then I just want you to know that New England Journal of Medicine and JAMA, which is were really well respected publications, are all their publications on COVID are open source right now. So those are really good sources. I know there's a lot of misinformation out there, but please, we need to fight misinformation as well. And this is I think my last slide. And this is very important to think about. We don't make the timelines the virus. The virus doesn't know it's killing 1 million people. It's just doing what it's supposed to do. So I know it's great to be able to have a party and to meet your friends. There's nothing, I mean, that definitely is something as human beings we all want to do. But the virus, we don't want the virus to win. So let's keep that in mind. So that's my last slide.
Okay, thank you so much.
Ended on time. Thank you.
Yeah, so we have a couple of questions, Nanette, from
Sure.
Jessie.
Yeah.
She says dexamethasone was
yeah.
reported in the news this week. Are you able to give any details regarding this drug?
So one, I will first off, don't start taking dexamethasone. Dexamethasone is it's quite a powerful steroid. You don't want to be using that without the supervision of your physician. It is only in that study that was published. It was helpful in ventilated patients, so patients who were in the who were mechanically ventilated. So yes, so it does. So because as we talked about the cytokine the cytokine storm, and a lot of the problems that are happening with COVID is actually because of the inflammatory response of the body towards towards the virus. It's not actually surprising that that the steroid actually is helpful. So.
Okay. From Anna Serkinia, thank you for a great overview. Do you know of any current studies trying to address how durable antibodies to SARS-CoV-2 are? Also, since viral RNA persists even after resolution of illness, what is a good test to make sure a patient is no longer infectious?
I don't actually, we're not there yet. There's no, I don't think of the different PCRs, I don't know which one is very sensitive enough to make sure that it's actually detecting real illness or reinfection. So unfortunately, I don't. Yeah, those are the big questions that need to still be resolved. How we're detecting? Yeah.
Sorry, I didn't mean to interrupt.
No, including so repeat PCRs and antibody testing. Yeah, unfortunately, I don't know. We're still we're only starting antibody testing. Actually, it's been available in Virginia for the past 2 weeks, 3 weeks. So there's not enough data. I don't think so, unless there's somebody else here who knows. I don't think so.
There's another question from, sorry.
I'm sorry, this is Paz. Nathalie, I do agree with you. I mean, as far as I know, based in the literature, there is nothing reported yet.
Yeah.
So we can't tell at this time.
Yeah, we're really very much in the first phase of this pandemic. So, and we're learning a lot. What I usually tell is what I know. Sometimes there's things that I know this week and next week is going to be different.
Wow.
So it's changing a lot.
Okay, we have another question from Mike San Juan. What is it in rheumatoid arthritis drugs such as hydroxychloroquine and Actemra that seems to be an alternative option for COVID-19 treatment?
And because they're anti-inflammatories. Again, they're attacking the inflammatory response of the body to the virus. So they're still very much additional or supporting treatments. The most important thing that hasn't been found yet is an antiviral that really will attack the virus itself.
Right. On a little more practical aspect, how would you assess the effectivity of those homemade cloth masks that people are using? Would you recommend them, or how do you make it more effective? Or
right, so I think most of the studies looking at masks still recommend a double cotton. It's a double, not just one layer. You need to have 2 layers at least. And there's supposedly some that put filters, but at least most of the studies are using just 2 layers of cotton. And the surgical mask and the N95, the reason why they're very effective is not because it creates a barrier. They have a electrostatic effect. So it's not just a barrier. It drives, it collects viruses through an electrostatic effect. So actually, when you can't just wash an N95, or you can't just wash a surgical mask and reuse it, because what you're destroying is how that electrostatic effect. So, and I think that's the thing that is hard to replicate in a cloth, unless you can find that kind of filter that does an electrostatic filter as well. I think those are available. So if you put that in between two cotton cloths, or with a cotton cloth, maybe that's another way to make it effective. I think one of the other things that I think what I see a lot as a problematic actually is how we wear the mask. I see it under the nose, it's hanging on one side, we remove it, we touch it, all that. Those all decrease how effective a mask can be. So those are another thing. So it's not just the material itself, also how we're using it. And it has to be really, it has to have a good seal as well. So that's another thing. And I think a lot of us are uncomfortable with it. We tend to loosen it and all that. So again, then that decreases how effective a mask is. Yeah. And you could see everybody who uses an N95, by the end of the day, it really makes a mark on your face because that's the seal that's the most, that's the best. And actually when everybody who are in the healthcare field, we do a fit testing every year just to make sure that the N95s we use are well fitted for our faces.
Okay. Are there any other questions or comments for our speaker? Please use the chat box or unmute yourselves if you want to ask a question directly. Yes.
Great. Thanks for the talk, Nanette. That was great. That's a very nice, concise presentation. So a couple of things though. Try to reserve the N95s really for the healthcare people.
Yeah.
That's just very, very important. So the surgical mask too. So we see that like the well visit, but that's still for healthcare. So try to really just use the cotton masks. And I think it's good that you just double it up. But the other thing too is try to avoid crowded places. That's a big thing. The studies have shown that anything where it's enclosed and a lot more people, you're literally aerosolizing the virus. So as much as possible in terms of activities, they've actually done studies on this. Mm-hmm. Open air with the physical distance of 6 feet away, it's really the least amount of risk. That's why, you know, with the phase 1, phase 2 reopening of the states, they're now allowing the outdoor dining more because it's outdoors. So again, keep that in mind if you're, you know, starting to venture out. Try to avoid enclosed places. And if it is enclosed, even opening a window is actually a very good way of trying to rid of aerosolized virus. So try to avoid enclosed places. And again, crowded places. Wear your mask. That's the most that you can do. Wash your hands frequently. I mean, you can't be obsessive compulsive about this, but just remember, I mean, it's for your safety. And we've been doing tests in our office now. We're a big pediatric group and we've been doing the swabs, and you'll be surprised though. These are kids who have been, according to the parents, have been home pretty much throughout this lockdown. The only person who's been going out is the dad who's been going to the grocery. There's just one person who's doing all these outside trips. And we've had quite a few of kids with positive swabs. They're presenting, you know, they're not ill, they're not in distress, but they're presenting with cold-like symptoms, runny nose, fever. Thank God we haven't had the multi-system inflammatory disease, but we've had quite a few with the swab. So just remember, it's out there. These are families who've been pretty much on lockdown, and now they're venturing out. So also the blood test, we already have that too. The Roche one is pretty good. It has about 80% sensitivity. The thing is though, you still have that 20 to 30% that's false negative. So if it's negative, you don't know what that means. You may have it, it's just not picking up in the test. But if it is positive though, well, that's a true exposure. So you've been ill in the past, you've been exposed, and the only benefit from knowing that is that, one, you've been exposed and you can potentially be a donor for the serum.
Yes.
But other than that, you don't know if it's neutralizing antibodies, they call it, which means we don't know if it's protective. So if the child or the person is asymptomatic, that's great. You know, it was a past exposure. But other than that, you still have to take all those precautions. A positive test doesn't really give you a whole lot of information in terms of immunity, but it's nice to know you've been exposed. So is it worth the cost? I don't know. If it reassures you, sure, go for it. But there's not much information that you can get from it. And you have to use a certain code just so your insurance will pay for it. So there's a little bit of insurance billing play with that.
Right.
Just you get to be, you don't have to pay out of pocket. But thanks for the talk, Nanette. That was great.
Thank you. I tried. One thing about the mask I didn't talk about this, just to also, there are N95 masks that you can buy in cost. I think it's Home Depot that have the valve. Please don't use that because that really is not a good mask. It protects the person wearing it, but it doesn't protect other people because it still is, if that person is has COVID and coughs up, coughs, basically it's still spewing out the COVID. So yeah, so it doesn't work that way.
Okay, that's good to know. I guess if there are no more questions, I'd like to turn it over to Jessie.
Hi, thank you everyone for joining our webinar series, especially our session. It was very informative. It's a lot of information. I know we all came here for a reason. We wanted to know more. And like Nanette said, we're in the early stage, so we probably have more questions than answers. But, you know, knowledge is power, so we're taking one step towards that. So thank you so much, Nanette, for joining us and sharing your expertise. It was very, very good talk.
Thank you. It's my pleasure.
All right, so I'd like to thank everyone for joining today's session. We hope that you have found the presentation very helpful. And we look forward to seeing you again next Thursday on June 25 for Coping in the Time of Corona, which is the last installment of our UPAA COVID-19 webinar series, And I hope that you found this session useful. Thank you very much for your time.
Thank you.
Thank you, Nanette.
And thank you to UPAA.
Thank you for all your support. See you next week.
Bye.